welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today we're going to talk about Metformin in Prediabetes, a vaccination pill for diabetes prevention in 65 countries. Now, India sits on a sugary iceberg. Prediabetes now affects more people than type 2 diabetes. While lifestyle changes still remain the cornerstone of prevention, there is a growing global recognition of the role of pharmacological support. Now, metformin, we all know, is already been approved for prediabetes in over 65 countries and including by the DCGI in India in 2022. Now, with a long-standing track record of efficacy, safety, affordability, and even ease of use, metformin is emerging as a practical option in diabetes prevention. Now, as we observe this as the Prediabetes Month, it's time to revisit the value of early intervention. Now, could metformin be the pharmacological vaccination pill against diabetes progression? Now, let's explore this today in our topic, that is Metformin in Prediabetes, a vaccination pill for diabetes prevention in 65 countries. Now, joining us today for this discussion is here Dr. Mala Dharmalingam, Director and Head of Endocrinology at the Bangalore Endocrinology and Diabetes Center, Bangalore, and Dr. Pramila Kalra, who is a professor and the Head of Department of Endocrinology at MS Ramaiah Medical College and Memorial Hospital, Bengaluru. So I welcome you both to Medical Dialogues, ma'am. It's a privilege to be having you both on board here with us today on this discussion.
Thank you, Dr. Nandita, for the kind welcome.
So we're talking about metformin in prediabetes today. That's a topic of discussion. So first question, ma'am, if I may ask Dr. Mala, why is prediabetes not as benign or complacent at a diagnosis as the term indicates, and especially if I'm talking about Indian context?
So if you look at the number of diabetes in India, there is roughly around about 123 million who are diabetics today, and maybe another 123 million who are not diagnosed having prediabetes or impaired glucose tolerance. Earlier, we used to feel that prediabetes was just a diagnosis for us for early capturing patients with prediabetes to prevent. Of course, prevention is the most important reason why we have to diagnose them early, but also we know that prediabetes is also a reason for both micro and macrovascular complications in people. So that is why today we are trying to even catch people as early as prediabetes, one, to prevent progression, and two, to prevent complications. And you said in India, we can hardly afford the number of patients that we have in India with diabetes. And as a genetic population, we are more prone for complications, whether it's cardiac or kidney disease, and we get them almost a decade or even sometimes 2 decades earlier than the Caucasian population. So to prevent all of this, it's very important for us to identify prediabetes and treat them aggressively rather than just say, okay, it's there, you take care, and patients most likely don't care, and the progression is almost like 36%. Varies from studies to studies, but general studies have shown up to 36% progression to diabetes is there.
Great, definitely, ma'am. Now, coming to you, Dr. Pramila, now are lifestyle interventions alone enough in prediabetes cases?
Yeah, so when we talk about prediabetes, as Dr. Mala has already alluded to, that the prevalence in India is quite high. We know from the ICMR INDAB data that around 15.3% may have prediabetes, and the data is available, and we know that there's a huge number of patients who are there. Some of these patients may progress to diabetes, some of them may revert back also to normal glycemia, and some of them may remain to be pre-diabetic. So we have to see that which patient will be probably progressing to diabetes, because there are a group of patients whom we know that has a very high risk of progression to diabetes. There is a group of patients we know that these patients may not progress, may revert back also. So the treatment modification has to be done as per the individual patient. We have to see that if a patient has very borderline pre-diabetes value like 5.7, 5.8, this patient we mostly counsel with lifestyle modification. We tell them to do regular exercise. If they are obese or morbidly obese, we can offer them drugs which are newer drugs available for anti-obesity. We can also think about giving them the dietary counseling as per their body weight, as per whatever they can follow. But there are a group of patients who have HbA1c very high, like nearing 6.3, 6.4. Now, this is just near to the diabetes range or beyond 6.1, we say. So these are the patients who have a higher risk, maybe, because we know that when we are talking about below 6 or 6.1, some of these may just revert back with lifestyle modification. But the patients who have HbA1cs ranging from 6.1 to 6.4 are the ones who have a stronger predisposition to progress to diabetes. Now, these patients, we have to again segregate that what is the family history? Is there a very strong family history? Are they obese? Are they if it's a woman, we have to see that if she had a history of gestational diabetes. I'll repeat this. If she has a woman, if she's a lady, we have to see that if she had a history of gestational diabetes during her pregnancy. So these are the risk factors where these women may have a higher risk of progression to diabetes. So these are the patients whom we can target to some extent with pharmacotherapy as well. So it's not that every patient with prediabetes will need pharmacotherapy, but there are patients of prediabetes, as I told, between HbA1cs of 6.1 to 6.4, a strong family history of diabetes, history of gestational diabetes in their pregnancy, or obese, and who are progressing fast. Like the last time we saw, suppose it was 6%, and now today HbA1c is 6.4. So I know this patient is progressing fast. So these patients may not just benefit with lifestyle modification alone. They may be needing pharmacotherapy, but again, to add that not every patient needs pharmacotherapy, we have to again decide which patient is the candidate. These are the candidates whom we can talk about pharmacotherapy, and we can discuss about the options of pharmacotherapy like metformin, where they can be offered this pharmacotherapy to see that if it helps them to prevent the progression to frank diabetes. But again, to add that not every patient is a candidate. Most of them will benefit from lifestyle modification, because if you see the studies, the best benefit has been seen with lifestyle modification. So no matter in case also they are put on pharmacotherapy like metformin, lifestyle modification is the key. They have to follow that alongside with that.
Great. Very well quoted, ma'am. Definitely lifestyle interventions will be an additional, that is the main key if they have to control their pre-diabetes state. So, ma'am, over to you, Dr. Mala. Ma'am talked about lifestyle interventions alone not being sufficient for management. Now, what is your take on the pharmacological management of pre-diabetes? Why do we have to start them early?
So once again, I fully agree with every point that Dr. Pramila made. On the road of pharmacological therapy, we should not forget the importance of lifestyle. Again, both of us reiterate that lifestyle is the key, and as she alluded, the diabetes prevention program showed a 58% reversal with lifestyle compared to 38% reversal with metformin and lifestyle. Unfortunately, many people do not follow lifestyle very strictly. So in those individuals who are not able to convert back to normal or normal glycemia, in those patients, we may try metformin. That is the only pharmacological agent which has been approved for prediabetes management as of now. There is a huge campaigning for SGLT2 inhibitors also to be added in the group for prediabetes, and studies have been done. But as of now, the DCGI has given approval only for metformin in prediabetes. Again, a person with prediabetes has signs of severe insulin resistance. He or she has acanthosis nigricans, skin tags, or is very obese and is finding it very difficult to lose weight. Weight is not a very simple phenomenon where you say, okay, you eat less and walk more, you're going to lose weight. There are many layers of weight loss. One is, of course, diet, which is the normal eating pattern where there are certain hormones which cause hunger and there are other hormones which cause satiety. But added to that, there is hedonistic eating. So people eat for pleasure. So that is something which is very difficult to control. So suppose someone says, no, I have a craving, I'm not able to do diet and exercise. Maybe in such patients, metformin can be introduced. I don't introduce metformin immediately because it sort of doesn't give them motivation to do lifestyle. So we say, do it, you can. And then if they are not able to, and we see a rapid progression to maybe like Dr. Pramila said, from 6 to 6.4 in 3 months, then possibly that is the time I would also put metformin as the drug to see whether we can reverse diabetes back to pre-diabetes back to normal, as that is what we all want. And we, again, like I said first, there is a risk that pre-diabetes is not a very safe zone. It has a risk for micro and macrovascular complications. We are aware of it. There's a huge risk of converting to overt diabetes. That also we are aware. But lifestyle is most important. And of course, in those patients who find it difficult, metformin is the drug of choice.
Over to you. Great, ma'am. So, ma'am, Dr. Pramila, ma'am gave us an instance about when she would prefer using metformin. So according to you, according to your experience, when would you use metformin in pre-diabetes? We all know it's a DCGI approved pharmacological agent. So in your based on your clinical practice experience, when would you start a patient on metformin?
So I fully agree with Dr. Mala, because what points she has put forth are the points we follow in our clinical practice. So just to tell the places where I would be using, or the type of the patient scenarios where I would be using metformin. So if you see the patients who come with the HbA1c between 6.1 to 6.4, and the patients who have rapidly progressed, like suppose last visit 3 months back it was 5.8, now today it is 6.3. So now I know that this patient is progressing very fast towards type 2 diabetes. This is a good candidate where I can think about, discuss the option of metformin. Patient who had a family history of diabetes very strong in the family and has severe insulin resistance signs, like not that we have to do HOMA-IR or insulin resistance parameters, but just by clinical examination. If they have acanthosis nigricans, which is blackish discoloration in the neck, or they have skin tags, they are obese, more waist circumference, these are all the candidates who have stronger insulin resistance or high insulin resistance. These patients will have a stronger predisposition for progression to overt diabetes. But again, to add, as Dr. Mala also pointed out, lifestyle modification is the key, because if we don't tell the patient to do lifestyle and we give them a medication, they will think that medication will do the job, which is not the right scenario, which is not the right message we are trying to give. What we are trying to say is lifestyle modification has to be done. It has to be continued and followed. The metformin is going to help in retarding the progression to some extent, but the major benefit will be from lifestyle, which has to be continued, because if they don't do lifestyle modification, metformin alone is not going to give that benefit. It is only going to come with lifestyle modification, which should be the top of the list, and then metformin. And these are the patients who will benefit from both lifestyle modification as well as metformin. But also to add that we have to also understand that the patients who may be at a higher risk of progression to type 2 diabetes sometimes may just benefit with rigorous lifestyle modification alone, and addition of metformin may not be required. So we also have to see that which is the right patient scenario. As I told, the patients who are progressing very fast from 5.7, 5.8, it has become 6.4, just nearing the over diabetes range of HbA1c. Patients who have a very strong family history of diabetes, signs of severe insulin resistance, clinically, acanthosis nigricans, skin tags, obesity, patients who had a history of gestational diabetes in their pregnancy. These are the candidates who may progress fast. So these patients will need, over and above lifestyle, sometimes addition of metformin, not always.
Okay, great. Now coming to you, Dr. Mala, now we're discussing about metformin. We know that that is one main pill which can be introduced apart from lifestyle modifications that one patient actually has to undergo. Now, according to you, what are the potential benefits of using metformin early in pre-diabetes cases?
So metformin has stood the test of time. I think we have been using metformin as the first line therapy for many years and decades also for the management of type 2 diabetes. So why did that happen? The main reason why a person develops diabetes is first pathophysiological mechanism is insulin resistance. So this insulin resistance can happen centrally, which is the liver, or it can be peripherally at the level of the adipose tissue or the skeletal muscle. So metformin majorly works at the level of the liver and also peripherally, wherein it inhibits glycogenolysis and glycogenesis, so that there is at the level of the liver, the glucose metabolism is much better. So that is why it is one of, and also peripherally, the utilization of glucose is much better at the level of the adipose tissue and the muscle. So that is why it has been the first rung of treatment for type 2 diabetes, because of it increases insulin sensitivity at the level of the liver majorly, and which is one of the main pathophysiological mechanisms in which diabetes happens. So that is why even in pre-diabetes, that's the first thing. First thing is insulin resistance. When insulin resistance goes on, and then at a certain stage, even the pancreas produces less insulin, then you become frankly diabetic. So the first thing to happen, and that is about a decade earlier than the onset of diabetes. So insulin resistance has started, even it may not even be pre-diabetic, it may be normal, but still insulin resistance has started. We are aware of that. And we also know it's a common soil for cardiovascular disorders, all metabolic syndromes, even hypertension. So if I have to sort of look at the pathophysiology, not looking only at control, then I have to start early at prevention. And of course, once again, insulin resistance best is to do lifestyle, diet and exercise. But since that is not possible for most, the next best thing to do is metformin, which has mechanism of action, which helps in reducing insulin resistance.
Great, understood, ma'am. Now, Dr. Pramila, what is the protocol that you follow in your clinical practice when you are recommending metformin for pre-diabetes patients? Any standard protocol, any set that you've, anything that you would recommend?
So it's very important to understand that first, like we decided that we have to start in few group of patients where we have decided to start. Then comes the question of dose, that what dose are we going to start and for how long we are going to give. Now the question for how long is actually very difficult to answer, because if you see most of the data or most of the studies, till the time you give, the effect is there, and once you stop, they may again revert back to their previous situation. So the question is first that what dose you are going to start. Now there are many studies which are available in literature where people have tried different doses, and we have our own clinical experience as well. So if you see in Indian scenarios, as an ethnic group, our patient actually needs lesser doses of metformin. So we don't start with a very high dose. And many of our patients may not tolerate a high dose also. There is data with 850 milligram twice a day where they have shown benefit in other ethnic groups. But in our ethnic group, we don't start with such a high dose. So what we do is, if suppose, for an example, I have a patient whose HbA1c is 6.3 and patient's body BMI is suppose 28, and I have to start metformin, then an AB dose would be either a 500 twice a day or 500 once a day to start with. Because what happens that if you start off with a very high dose, sometimes they may not tolerate, they may have issues, or some of the patients may feel hypoglycemic, though it is a very, very uncommon thing. So most of the times we don't get hypoglycemia with metformin, but the studies are available with all the dosages. Some studies have shown that 850 milligram twice a day is the AB dose. But in our population, we don't start with 850 milligram twice a day for pre-diabetes. I'm talking about. I'm not talking about diabetes. For diabetes, we go to a higher dose, but this is a pre-diabetes patient where I have to give it for just retarding the progression to over type 2 diabetes, and I would be comfortable starting either 500 twice a day, which should be a good dose for this type of a patient, 500 milligram twice a day, and then see how the patient progresses, how much the lifestyle is helping, and also see if the patient is tolerating the drug. There may be a group of patients who may not tolerate even 500 twice a day, then I have to shift back to just 500 once a day. Even there are studies available with 250 milligram 3 times a day. That data is also available. But giving 3 tablets a day will be very, very difficult for some patients, and they may not comply because patients will say, I don't even have diabetes and you are trying to give me 3 tablets in a day. So the compliance will definitely be less. But there is data even with 250 milligrams 3 times a day. But we don't normally use that dose in pre-diabetes unless there's some tolerability issue where I have to use 250 only. But normally what we do is we start with 500 once or 500 twice a day, like in the patient scenario or the case scenario which I told you. I would go with 500 twice a day, see how the patient is doing on follow-up, how much weight loss, lifestyle is helping, and then up titrate or down titrate as per whatever the readings I'm getting. Sometimes the patients may do very well. And suppose the patient has lost 5 to 6 kgs of weight with lifestyle, and patient has come to a range of 5.6, 5.7, I may reduce it to 500 once a day, and then again follow up and then take a call. We also have to understand that whenever you talk about any hyperglycemia, be it just borderline hyperglycemia, these patients will have a sort of an inflammation, which Dr. Mala alluded to. And this all inflammation leads to endothelial dysfunction and multiple other problems. So this is how it is setting up the vicious cycle of complications, both microvascular as well as macrovascular. So in a way, when we are giving any of the drugs which are bringing down the hyperglycemia to some extent, we are also helping in reducing that inflammation and the complication development. So this type of a scenario also helps to some extent in bringing down the patient's overall complication progression. So this is why in some of the group of patients, like we discussed, addition of metformin in a pre-diabetes case may provide additional benefit over and above the lifestyle modification in progression to type 2 diabetes.
Great. Now, Dr. Pramila quoted about the dosage. She elaborated on what are the different types of dosages depending upon the individual's condition. So, according to your clinical practice, ma'am, what dosage would you initiate in pre-diabetes patients? What dosage of metformin would you initiate?
So, like Pramila said, usually I start with 500 and go to 750. There is evidence, there was a meta-analysis which showed that 750, like 250 thrice a day, even they finally said 750 milligrams per day is a good dose for given for a period of 3 years, can revert pre-diabetes back to diabetes. So with that rationality, I do give, but every patient sitting in front of you is different. So some patients require only 100, some people require 850, some require 750, some cannot even tolerate 250. Sometimes we give in gestational diabetes 250 and they say, no, madam, we can't tolerate because of the GI side effects. So yes, usually I will start with 500, go to 750 and keep encouraging them to do their lifestyle to get to reversal. But generally, you have to possibly give for a period of a year or more, data says 3 years, for them to revert back to normal.
Okay, great. So, ma'am, coming back to you, Dr. Pramila, do you have any specific recommendations when you start metformin in your pre-diabetes to improve the GI tolerance in the early weeks of treatment, which can otherwise disturb even compliance for that matter?
Yeah, this is a very pertinent question because that's what I was already talking about. That whenever you are talking about starting metformin, whether be it pre-diabetes or even type 2 diabetes, you always have this question that whether my patient will tolerate the full dose. And when you are talking about a scenario where the patient has pre-diabetes, like Dr. Mala also told, the studies have clearly shown that the data is there with lower dose. So we don't have to go to that 2 grams or 2.5 grams of dose. We have to start off with a lower dose, maybe 500 to 750, 850. Also, some studies have shown 250 thrice a day. So that's what, when we start, what we tell the patient to start with once a day. So if a patient, like I told you, like HbA1c of 6.4, has a BMI of 28, I may start off with 500 milligram once a day. And I may give it in the afternoon time sometimes. Because what happens, many of our patients take a good heavy afternoon meal also. So we tell them to take in the afternoon, and best tolerability is just after the meal because they tolerate it better. They have less GI side effects. I normally don't start in the night because sometimes in the night, if they get any bloating or something, it disturbs their sleep and that leads to non-compliance. Another time which I start is in the morning, just after breakfast. They take it and it works for the full day. So that's also another time. But sometimes the patient says, I'm going to office, I don't want to take any diabetes tablet, and they'll be afraid. So I tell them, okay, you carry it with you. When you take your lunch in the afternoon, take it after that. So 1 tablet a day, if I have to start 500 or maybe go up to 750 to 850 milligrams a day, I would start off with morning dose or an afternoon dose, preferably not in the night. But There are patients who have predominant fasting hypoglycemia. Like I have some patients of my pre-diabetes who will come with fasting of 120, 122, just nearing the diabetes range, but their postprandials will not be so high. It will be just 120, 130. So if I give metformin in the morning to such a patient, they may feel not very good during the day. Though metformin does not cause any severe hypoglycemia, but there may be patients who may feel hypoglycemic, and we know that in very small percentage of patients, it can cause hypoglycemia. So I would not give those patients this tablet in the morning or afternoon. In that type of a patient scenario, I will give 500 milligram in the night after dinner, and then see how the fasting is, and their fasting comes down. We have patients who have HbA1cs of 6.3, 6.4, but their fastings may be even in the diabetes range of 127, 128. So these patients do very well with metformin once in the night. A 500 dose is good enough, 500 milligram is good enough to start with. We can increase to 750 or 850 once a day in the night and control the fasting, because sometimes you will see the HbA1c hasn't reached the target of the diabetes range beyond 6.5 to 6.5 and beyond, but their fasting glucose values may be in the diabetic range. And as Dr. Mala was telling about the pathophysiology, that the hepatic glucose output, the stored food is much more, and these patients will have much higher hyperglycemia in the morning. And we know that fasting glucose being high is again is also connected to complications and problems. So that's why these patients are the case scenarios where I will give it in the night after dinner, 500 to start with, go to 750 or 850 milligram as per the need. Suppose it is not getting controlled, I may go up to 1000 also.
Great. Now, my last question is to both Dr. Mala and Dr. Pramila. Now, in the current pre-diabetes landscape of India, how important is metformin in the larger picture for diabetes prevention, and what is your call to action for the medical fraternity to actually tie down the diabetes epidemic that we are facing? So, Dr. Mala, if you can start.
So I think this is a very, very important question, more of public policy also. So rather than talk about pharmacology treatment, first identification is most important. So what can I do? I'm not part of government, so I can't relay any government rules. So what could I do? Possibly what I can do is, with every patient who comes, they are accompanied by wives or their kids. So screening each and every patient with just a random blood glucose at your own clinic or hospital will go a long way in identifying dysglycemia. So patient says, no, I'm not diabetic, but when he tests is random, it may come 150 or 160. So we say, okay, it's not good. So tomorrow you do a proper test and let us know where you are. And then we can identify whether you're pre-diabetes. These are a very good population because they've already seen their parents suffering, going to doctor, having symptoms of hyperglycemia. So if you target them and say, okay, see, this is what it is, and this is a family support also, where you can start doing the diet just like your mother. And just to reiterate, a diabetic diet is just a normal diet. People think that diabetic diet is something very difficult to do. It is a normal diet that all of us eat actually. And it only thing that is missing is the sugar or jaggery or the sweetness. And this is something which we should not encourage anyway for everybody. Even for others, just about a teaspoon per day is okay. And diabetes, maybe half teaspoon, because that's allowed actually, half teaspoon per day. So just go on a diet and go on exercise and then keep them informed. So they see their own blood glucose. They don't forget about it. After 3-4 months, they can recheck. And then if they see that they, in spite of all this, they are not progressing to reversion, or they're progressing with their HbA1c in spite of their best efforts, then that is the time. See, all the time, starting medicine always has to be with the person's acceptance. Otherwise, they won't take. They'll take for 10 days and they will stop. No, I don't want. So they should say, yes, doctor, I think I should take this medicine now. I'm not getting much success with my diet. I am doing the best I can. But maybe it is stress, or maybe it is their time schedules. You can understand that India is always a country in a hurry. We are always hurrying for everything, whether it is standing in line at aeroplanes, or we don't stand in line. So we don't wait for anything. So that is why one of the reasons I feel we are so prone for diabetes, because everything has to be done so quickly. So maybe just counseling them to a large extent can prevent. And in those patients we can't prevent, then of course we may need a small dose of metformin and to see that they don't progress. And if many times I find signs of insulin resistance, like Dr. Pramila said, acanthosis nigricans, see severe darkening at the nape of neck. We see it so often in obesity itself. Then definitely giving metformin makes a large difference, because that's not a skin problem. Giving metformin, their colors will change, of the acanthosis nigricans, wherever young girls are quite traumatized by their dark pigmentation, underarms, especially girls in the marriageable age. So there, of course, metformin works like magic. All their pigmentation will go off, their pre-diabetes will come down, because that is the age where they're so willing to listen to us, to lose their weight, to revert back to diabetes, knowing fully well that pre-diabetes and pregnancy means that that is gestational diabetes. Pre-diabetes in pregnancy is gestational diabetes, right? So they would want to have insulin and all of that in pregnancy. So they really cooperate and do their best to revert back. PCO girls. But so definitely counseling them, and then if lifestyle fails, starting metformin is the best way to go forward, and identifying early. I think these are the main points that I would like to make.
Anything that you would want to add to this, Dr. Pramila?
Yeah, so I agree with Dr. Mala that whenever we talk about management, am I audible? Yeah.
Sure.
Yeah. So I agree with Dr. Mala that when we talk about management of pre-diabetes, it's picking up the right case and picking up the patient is important, because we need to diagnose and screen on time, because we get so many patients now who come for health checks and they pick up that they are pre-diabetes. So that's the right time when we can counsel them clearly about lifestyle modification and the risk of progression to type 2 diabetes and the risks associated with pre-diabetes, because they may not understand that it is significant at that age and they may think that it is just a report. So we have to counsel them that this is the time when you should start lifestyle modification. We have to see to it that the whole family is doing it, because what happens if one person is diagnosed to have pre-diabetes, that's a good enough opportunity to tell the whole family to follow the same lifestyle, because that is what we call it as healthy lifestyle. So we don't call it as diabetic diet or any other diet. It is a healthy diet, and that everyone needs to follow. Addictions are very important, which needs to be discussed, and patient has to be counseled about stopping them, because smoking and alcohol is something which can even make this progression faster. So that's another thing which we need to talk to them about, especially now we are seeing more and more addictions even in women. So we have to talk to them about it, that they may be even more predisposed to problems because of this. Also, we have to talk to them about the need of pharmacotherapy as and when required. So if you have a patient, like we discussed, who is obese, who is having a fast progression of the HbA1c values, who is having severe signs of insulin resistance, who has a very strong family history of diabetes, who has a history of GDM or who had GDM in the pregnancy time, are candidates who can be counseled about need of pharmacotherapy like metformin, to see how they get benefited with that. A low dose of metformin is good enough. We normally target for pre-diabetes management with pharmacotherapy in the younger population. Beyond 60, we don't have much data. So we have data mostly in the younger population. That also we have to remember. And we have to see that these patients are counseled enough for their lifestyle at every visit, because they should be clearly told that lifestyle modification is on the top of the list, and then the pharmacotherapy comes after that.
Great. So thank you so much, Dr. Mala and Dr. Pramila, for giving us all your valuable insights on this vaccination pill that we're talking today. We discussed about metformin in detail. Thank you so much for giving us your valued information. And we just hope that there are more and more people who actually come down for an early diagnosis, so that prompt treatment can be initiated at the earliest. So we catch pre-diabetes at an early stage, so the epidemic gets controlled to a larger extent. So thank you so much once again for joining us today at Medical Dialogues.
Thank you. Thank you, and good day.